Dr. McCormack is an attending physician in the Division of Endocrinology and Diabetes and an assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. She cares for children with pediatric endocrine disease. She has a clinical interest in patients with endocrine dysfunction related to individually rare metabolic disorders such as primary mitochondrial disease, Friedreich ataxia, and lipodystrophy. She also has an interest in inherited and acquired forms of hypothalamic and pituitary dysfunction, in particular those associated with abnormal energy, balance, and obesity like craniopharyngiomas. As a physician scientist, she investigates the neuroendocrine systems that regulate energy balance in humans. Dr. McCormack is a member of the Raymond A. Wood Foundation Scientific Advisory Board. So for those of you who have not had the pleasure of meeting Dr. McCormack before, she is a pediatric endocrinologist at Children's Hospital of Philadelphia. And for those of you on the East Coast that are looking for a pediatric endo that knows her stuff when it comes to HO, this is your doctor. So a couple housekeeping things. During the discussion, you can submit your questions using the QA feature at the bottom of your screen or the chat. And while you're there, you can also choose to upvote questions that you like. So I guess if you see questions that somebody else has asked, and that's also a question that you have, rather than typing the question again, you can just upvote it. And then Dr. McCormack will speak, and then following the presentation, the panelists will answer your questions. Also note that we have a poll feature which will be launched. So I do encourage you to take part in answering these poll questions, and we can share those results at the end of the session. So with that said, I'm going to turn the talk over to Dr. Shana McCormack.
Oh, thank you, Marcy, so much for the very kind introduction. And thank you to Amy Wood and the Raymond A. Wood Foundation for inviting me to speak, and to all of you who have joined us. I know your evenings are full and busy, so thank you so much for taking the time. We really appreciate it. So as the introduction mentioned, I'm going to speak today about intranasal oxytocin in children, adolescents, and adults with hypothalamic obesity. And here are some disclosures related to my industry-related connections. None are relevant for this talk. So I'm going to begin with a clinical case. This is a patient I met when I first arrived at CHOP, now going on 10 years ago, who was 12 years old at the time. She'd had a suprasellar astrocytoma, a hypothalamic pituitary tumor, and associated hypopituitarism. And this is her BMI chart. You can see she acutely lost weight during her treatment, but then shortly after gained weight quite acutely, and then experienced acute weight loss that was related to the onset of type 2 diabetes. And the question that faced us then, and that still motivates a substantial part of my work now, is what can we offer this patient and patients like her? So the outline for today's talk, I want to begin by thanking everyone for this pilot study, particularly research participants and their families. These were just amazing folks to partner with. They taught us so much. The goal of this study was to gain experience and insights, and much of those insights came from the families themselves. Coordinator teams, collaborating physicians, everyone was terrific. These are the Doris Duke Foundation was our funding source for the trial. I'm very hopeful in the course of today's session, my own learning will continue. So I really look forward to the discussion after the talk. With respect to an outline, I'm going to outline very briefly the rationale for testing oxytocin in this condition. I'm really excited for the poll questions that the Raymond A. Wood Foundation will put forward. I'll describe our pilot trial and then talk about next steps. So we're all on the same page. I imagine this group is really familiar, but with respect to hypothalamic obesity, one question we get a lot is, how do you distinguish hypothalamic obesity from so-called common obesity or diet-induced obesity, or the other forms of obesity that affect a substantial proportion of the population? So this resource from the National Organization for Rare Disorders that I and some colleagues recently updated reviewed some of that literature. And one proposed set of criteria is that the individual have a brain tumor or some other injury that affects the hypothalamus, that they experience an excess rate of weight gain related to the diagnosis of their injury or its treatment, And some individuals also suggest that evidence of an endocrinopathy or pituitary hormone dysfunction be included as additional support for the fact that there's damage in the hypothalamus leading to weight gain. So this is the neuroanatomy. I'm not going to go into a lot of detail, although I find this incredibly fascinating. And I know we have some really knowledgeable attendees on this call. But just to orient you, why this very small area in the brain. So this is in the inset, shows you where the hypothalamus is. And then this blown up view shows you all the nuclei, the various important cells in this region that affect metabolism. So there's cells here that regulate eating behavior. So that can lead to excess appetite when those cells are injured in the arcuate nucleus, which is here. There's cells that affect energy expenditure. Particularly, they do this by affecting sympathetic nervous system tone. So folks are familiar with the fight, flight, or freeze system. That system affects how our body burns energy. And what two of the nuclei that affect that system are the paraventricular and arcuate nucleus. So those nuclei here. There are cells that affect energy storage that can lead to chronically high insulin levels in folks with hypothalamic obesity. Also cells that affect sleep and circadian phase, which affect metabolic rate and weight trajectory in the suprachiasmatic nucleus, which is here. And also, of course, very relevant for today's talk, the two nuclei, the paraventricular nucleus and supraoptic nucleus, produce oxytocin and project it to the posterior pituitary. So much going on in this really small space. And we know from lots of epidemiologic studies that the more injury one has to the hypothalamus, the more likely excess weight gain is going to occur. I'm introducing this surgical scoring system that our colleagues, Christian Roth and Francisco Perez out at University of Washington have generated, because I'm going to raise this in the course of explaining the trial. So they've developed a scoring system where you look at several different important slices in the MRI of the individual who's had a brain tumor and quantify, meaning assign a number to the extent of damage. And that way we can not only predict the future change in BMI, but when we do something like a clinical trial, we have a number to help us understand the extent of hypothalamic damage in the individuals we've enrolled. We know that more hypothalamic injury is also associated with excess obesity-related health problems. So why oxytocin? I learned in the course of preparing this talk. I have a teenage daughter that Billie Eilish even has a song about oxytocin. If you haven't checked it out, it's quite good. It's a hormone that's gained a lot of interest, but why in this condition? Well, I already showed you in the diagram that oxytocin is made in this important area, right? So deficiency of this hormone in folks who've had hypothalamic injury is certainly plausible. And in animal studies, when we give these to model animals, oxytocin can promote fat loss while sparing lean mass, sparing muscle. There's one study, and I'll mention more about it in a moment, in adults with common, so not hypothalamic obesity, common obesity, where exogenous, meaning therapeutic oxytocin, led to weight loss by decreasing energy intake, how much food people ate. In previous studies of oxytocin, it's been shown to be well tolerated, but there's a theoretical risk, a concern for precipitating low sodium levels, hyponatremia, when given exogenously, in particular to folks with hypopituitarism. And that's because if you look at this diagram here on the side, oxytocin, which is just 9 amino acids long, is very structurally similar to vasopressin. So the synthetic form of vasopressin, desmopressin, DDAVP, is what many folks with hypopituitarism and diabetes insipidus take. So because these two are structurally similar, there's a concern of if we give folks with, especially with diabetes insipidus who are on DDAVP, doses of oxytocin, could we cause water retention and low sodium levels, which we'd want to avoid. So an important safety considerations, we think about the therapeutic role for this hormone. Another line of research that's really interesting to me that helps us think about the rationale for testing oxytocin is the study of a related molecule called Carbitosin. So Carbitosin is an oxytocin analog that has been tested in Prader-Willi syndrome. Many folks will be familiar. This is a genetic condition that leads to obesity. Many folks experience hyperphagia or excess appetite, excess eating behavior. And in a phase 2 study, Carbitosin and placebo, so Carbitosin was blue and placebo was red, was given for 2 weeks. And the score here on the y-axis of the graph is how hyperphagic, how hungry the people were, how much excess hunger they had. And you can see there was a benefit for Carbitosin with respect to decreasing hunger. So that's another kind of promising angle to say, gee, maybe this hormone is worth investigating in hypothalamic obesity. And then folks familiar with the Raymond A. Wood Foundation may have already listened to a terrific learning series seminar on oxytocin and hypothalamic obesity. A case report on the use of oxytocin has been published, so an individual patient's experience that showed that this might be promising. There's some challenges around studying intranasal oxytocin, though. One of the foremost of which is that it's not an FDA-approved medicine in the United States. So folks who are getting oxytocin in the United States typically intranasally are getting compounded formulations. So from compounded formulation from one to the other, there may be some differences, right? So interpreting experience between different people who are using different formulations may be challenging. There's uncertainty around the most appropriate dose to use. As folks with hypothalamic obesity know well, there are differences between patients in how they present and how they tolerate different medicines. All of that makes the experience, interpreting the experience more challenging. But I would certainly direct folks who are interested to this webinar if the Wood Foundation still has it recorded, because it's great background. With respect to figuring out if there's deficiency in hypothalamic obesity, that can be tricky to assess. And the reason is this: what we're really curious about is whether or not there's deficiency of oxytocin in the hypothalamus and pituitary. But of course, we don't sample there directly, right? Like that would be really difficult to do. So instead, we look at peripheral, so measures outside the brain of oxytocin, which may or may not show us what's going on in the brain. That said, there have been groups who have tried to do this. I'm highlighting one study that measured salivary oxytocin, so oxytocin in the saliva, in individuals with craniopharyngioma as well as healthy control. So the folks with craniopharyngioma are in the black circles, and the controls, the healthy volunteers, are in the gray circles. And they looked at the change in oxytocin after a meal and found that individuals who had craniopharyngioma and obesity had less of a change in salivary cortisol after meals. Interestingly, they found that fasting oxytocin levels varied with the extent of hypothalamic damage, but perhaps not in the way you'd expect, because those with posterior lesions, so lesions in the back, actually had levels that were relatively similar to those with no hypothalamic involvement. So lots of questions. Oh, this is exciting. Now we get to have our poll. So our colleagues at Raymond A. Wood Foundation are going to put up some poll questions, and I'm hopeful our attendees will be able to answer those. Oh, look, here they come. So I'm going to read the questions if anyone can't see. It says, have you or the person you cared for taken intranasal oxytocin? So if yes to that question, I think you can interact directly, by the way, with the poll on your screen, is what I understand from the organizers. And then if yes to oxytocin, what is the main goal of oxytocin treatment? Weight loss, decrease in appetite, improve social function. And if yes, what was the dose used? And I think Amy mentioned that there may have been some transcription errors in the dosing. So less than 4, 4 to 8, 8 to 16, or 16 to 32 or more. So we'll just do your best on that last one because we know the formatting is a bit odd. So I'm just going to give folks a few minutes to vote. And then, or not a few minutes, we'll give them just a little bit. And so there may be people who are preferring not to vote, which is totally cool also. Or folks who, might have been like me and not figured out how to respond to the poll on the screen. So as I'm looking at the answers coming in, we have a handful of folks who are responding. So some of them have tried intranasal oxytocin, others not. It's interesting, weight loss was the goal for one person, improved social function was the goal for someone else. And dosing, some folks were not sure of dosing, and then kind of the 4 to 8 dosing. So then, and then interesting, if someone took oxytocin, did they find it helpful? Someone said yes, and someone said not at all, and others said they weren't sure. So I really appreciate people's responses. I don't want to wait too long to continue, but I think we'll get to, actually, I'm going to refer back to some of the answers to the questions that you all have provided as we continue with the talk, because I think they'll highlight some important points. So let me move on now and tell you about the trial itself. So let me tell you about the trial itself. Oh, you know what? This is, oh, do I have to share results to the organizers? It keeps just popping up on my screen. I don't want to miss the opportunity here.
No, you're good, Shana. Everyone should be able to see it.
All right, awesome. Cool. So this is the Oxytocin trial design. So it's a randomized, double-blind, placebo-controlled crossover trial. So one of my goals for today's talk, for folks who aren't familiar with clinical trials, to give you a little bit more of a sense about them, so you can be more informed in deciding whether or not to participate, and also help us design future trials, because we really welcome the input. So randomized means none of us get to choose which treatment. Double blind means we don't know what people are on, and placebo controlled means folks initially were randomized to get either, so coin flip, they either got oxytocin or placebo. And the crossover design means that they get this dose for 8 weeks, and then there's a 4-week what's called washout, where they take nothing. And then they switch to the other arm. They switch, if they got oxytocin, they switch to placebo. If they got placebo, they switch to oxytocin. And the benefit of this design is that we get to compare people to themselves, right? So many traditional designs will just have 2 groups. Some folks will get oxytocin and some folks will get placebo. But then those 2 groups, even if you use randomization, can sometimes be different. And we know there's lots of differences between individuals with hypothalamic obesity. Also, this design gives everyone the opportunity to get active treatment, which is an important experience for some people. It does mean that there's more time commitment for each individual person. So thanks again for the folks involved in this study. Our participants were between the ages of 10 and 35, all had hypothalamic obesity according to those criteria that I presented at the beginning of the talk. We used a formulation of intranasal oxytocin called Syntocinon that we imported from a pharmacy in Switzerland. So Syntocinon is approved by the European authority that's analogous to the FDA. It's not approved there for hypothalamic obesity. It's improved for induction of lactation so that women can lactate. But we chose to import it because it's a very consistent formulation, and pharmacologically, we knew that when we give it to different people, it would behave at least the same way with respect to its stability, like how long it would be good for and how we could store it. So dosing. We used size-based intranasal oxytocin, so more for larger individuals and less for smaller individuals, of up to 20 to 24 international units at meals. Our protocol did give us permission to decrease the dose if we needed to, if people were experiencing side effects. And we gave this for 8 weeks, either in the first block or the second block, depending on randomization. So lots of folks, because dosing is a big question here, were curious about the rationale for this dosing. So I'll tell you a little bit about it, although we could spend a whole hour discussing this decision for this particular pilot. So this graph here at the bottom, this is from the study of individuals with common obesity who took oxytocin and experienced weight loss. So the week 0 is before treatment and week 8 is after treatment. And the dose they used in that study was 24 units at meal times. So we had literally one trial in adults without hypothalamic obesity where we saw a benefit. We also knew from FDA that we would not be permitted to do dosing beyond around 8 to 10 weeks, because there wasn't, at the time that we put in our application to the FDA to do this study, there wasn't a lot of long-term safety data in children. So we didn't have a whole lot of time to march through lots of different doses. So our rationale was to choose this dose that had been shown in a previous trial, and also outlined kind of the highest dose that we may ever wish to use, so that we could gain some important experience with respect to safety. And so that we know if we see an effect at that dose, great. Once we know that we have safety at that dose, then we're pretty confident we have safety at lower doses as well. So that's that's where we started to gain some experience, but I'm happy to talk more about that in question and answer. Our primary endpoint for this study, so I asked you all in the survey questions, like, what was your main goal in starting Oxytocin? And, you know, as their answers were kind of coming in, some folks had highlighted weight loss, some folks had highlighted social function. I would be curious if there are other people for whom, if weight loss was the priority, addressing hyperphagia or excess appetite was also really important. So when we're doing a clinical trial and submitting our application to FDA, for most designs, typical designs, we're asked to choose and highlight a primary endpoint, meaning what's our main goal? Like, what are we mostly focused on? We can assess other factors, but how do we, you know, what's our primary outcome? And we chose weight loss as endocrinologists, but there's other outcomes, including hyperphagia and social function, that are really, really important and deserve attention. The interesting thing about choosing other outcomes like hyperphagia or like social function is that if we chose one of those outcomes for the main outcome of the study, then we would need to restrict our enrollment typically to folks who already had abnormal values for those. Because if we had people who didn't have hyperphagia or didn't have impaired social function, then there would be nothing to make better. And I know that there's so much difference between individuals with hypothalamic obesity. For some, hyperphagia is an issue, for others not. For some, social function is an issue, for others not. So that's always a challenge in thinking about our study design. We also looked at energy balance and social function in the course of our study so that we could gain some experience. And we had hoped to enroll 20 individuals to be able to detect a weight loss that's comparable to around half of what was seen in the otherwise healthy individuals with obesity. So the inclusion exclusion criteria for a clinical trial means what are the rules for who's permitted to enter? Most of these are around safety, right? So we wanted folks who were stable after their tumor treatment, who were stable on any medicines affecting appetite or hormones, except for small adjustments. We didn't want folks with brittle diabetes insipidus because of that concern for hyponatremia that I mentioned. Similarly, we excluded folks with diabetes who were on insulin or clinically significant liver, kidney, or heart disease. Also with prolonged QTC interval, this is a cardiac condition and abnormality on the EKG that I'll speak more about in a moment. We didn't want anyone with a history of recent surgery, a recent seizure, or who had already undergone bariatric surgery, and no active psychotic suicidality or substance abuse, because it's a medication that acts centrally, that acts on the brain, that those individuals might be more vulnerable to problems. So this is what's called a consort diagram. This is where this is how we're required to report clinical trial data, where we at the top have anyone who gave verbal consent for telephone screening, and we describe what happened to them, right? So 19 of them were not eligible, and the reasons are listed here. I won't go into that in the interest of time. Some folks declined to participate. So part of this trial occurred during the pandemic, so lots of logistical barriers for folks to join us. So for those who are interested, we had 18 undergo in-person screening, some of whom were ineligible, and then 13 were randomized, and 10 made it through all of the study procedures. So a few stopped early. One who stopped early was related to time commitment and perceived lack of efficacy, and 2 met stopping criteria related to the EKG. So I'm going to go over more of what that means in a moment. Overall, we were fortunate that no significant safety events over the course of the study. I'm going to go over those effects in just a moment as well. And for the analyses I'm going to show you, for safety analysis, we include anyone who got at least 1 dose of oxytocin. And for efficacy, when we see what happened, our statistical models, meaning what the statistician analyzes, permits us to include partial data. So include folks who may have completed the study early. So telling you a little bit about this cohort, we learned a lot from them. I said there were 13 individuals randomized, 9 were children, 4 were prepubertal, meaning they hadn't undergone puberty yet. All had been treated for brain tumors. 9 of those were craniopharyngioma. Pituitary hormone deficiencies were really common. 9 individuals had diabetes insipidus. You remember that hypothalamic injury scoring system I mentioned? It goes from 0, which would be like no injury, to 7, which is the highest degree of injury that scoring system that scoring system calculates. The median, so like the middle value, was 5.5, so fairly extensive hypothalamic injury. And that's consistent with, this is a different clinical trial that I'll reference in a moment, done by my colleague Christian Roth in Seattle. So pretty similar to other trials that have been performed. Individuals had obesity. We were able to draw some insights about eating behavior and hyperphagia. So people in our trial were very variable with respect to their eating behaviors. Overall, though, on average, they reported similar disinhibition. So being disinhibited would make someone eat more, and similar hunger to a different study conducted in adolescents who had obesity and binge eating disorder. So more than so-called common obesity, but similar to a cohort with binge eating disorder on average, but with lots of variability between people. We used a scale to measure hyperphagia, so excess appetite, that's been developed for individuals with Prader-Willi syndrome, that genetic disorder that I mentioned. Again, there's some variability. Hyperphagia that was present, so it was there, but less on average than individuals with Prader-Willi, which clinically in my mind makes sense as well. We included what's called a family function scale that my colleague Matt Hawking from psychology has taught me about. And similar to other brain tumor survivors, 36% of participants scored in the problematic range for family function. This is not my primary area of expertise, but it's just an incredibly important area. And I really appreciate the collaboration I have with Matt and others to get a better handle on the psychosocial experiences of our survivors. So this is the primary outcome. This is body weight. So I'm showing you the primary data. Like, this is each person's weight measurements over the study. So let me take you through this. There's arm 1 and arm 2. Arm 1, the people here got oxytocin first, then a washout where they got nothing, then placebo. Arm 2 got placebo first, then the washout, then oxytocin. And so each of these lines is a different person. And what we would hope, right, is that the oxytocin line would go down with respect to body weight and the placebo might stay stable or go up. That would be our wish. You can see here, there's one person in the oxytocin arm here who had some weight loss, although this individual experienced the weight loss actually started to experience this weight loss between the placebo phase and starting oxytocin before they even started this. So it's interesting when we monitor people across both phases. So on average then, statistically, we did not find for this pilot study and this dosing regimen that we used a significant body weight loss. We also looked overall at dose adjustments, like when we had to decrease the dose based on people experiencing what could be side effects. So we had to make dose adjustments in individuals with placebo and oxytocin, both related to the QT interval, which again, I keep promising I will tell you about, so GI symptoms and to fatigue. So this is the QTC interval. So folks may have seen an EKG. This is what an EKG tracing looks like. The waves here are Q, R, and T, S and T. So the QT interval is like how long it is between this Q wave and this T wave. And when it's prolonged, when it's longer, that can increase the risk of having a cardiac arrhythmia. And we found a fairly high burden of QT prolongation in our cohort. So 2 out of 18 at screening and 5 out of 13 randomized. So that was a high burden, but I'll show you some data in a moment that this has actually been documented before in this cohort. I'll also mention overall with respect to other side effects, folks experienced nosebleeds, some nasal irritation, as well as headache and nausea, not statistically different in oxytocin versus placebo. So with respect to the QT interval, I'm citing here a previous study, not related to oxytocin, just a different cohort where folks looked at cardiac problems in individuals surviving craniopharyngioma and found very similar rates of QTC interval prolongation that might be related to medications people use or electrolyte abnormalities or cardiac structural defects. So an important thing to bear in mind, since some medicines can prolong this interval, and clinically I'm more aware of this in my own practice, just that there's a background rate of prolonged QT in this cohort, but we did not find evidence that oxytocin either acutely or over time changed this. We think this is something that's a characteristic of the cohort that might be present. We looked at some additional measures including eating behaviors. So we had some scoring instruments, like some questionnaires that folks filled out, as well as how many calories they ate at a buffet test meal. And we didn't see consistent differences related to oxytocin. We did see a benefit with respect to self-reported anxiety for oxytocin, a small decrease in a self-reported anxiety scale. We did not see changes in depression, cognition, or social function. And reaction time on what's called a stop signal task, which is a measure of impulsivity, seemed to improve by a small amount without sacrificing accuracy. So maybe some signals here of some other benefits. We did make peripheral blood measurements of oxytocin, and we're still working on analyzing those now. So I'm going to just spend a minute summarizing this trial, and then a few minutes, Marcy, describing some next steps, and then we'll move over to questions because I see some already coming in. So recruitment of this cohort, even during a pandemic, is feasible. The regimen that we chose in the 8-week duration, we did not find an average change in body weight. We did find that it was overall well tolerated. And we did see a high burden of prolonged QTC interval in this population that others have found as well. So questions to inform our future study, like what I'm curious about for next studies, like what are the biomarkers? How do we know that oxytocin is deficient or that it's working, right? So I mentioned different outcomes that people are looking for, like which is the right one to target, because how we target it will help us really guide an individualized dosing. And what I'm most interested in as a next step is there's a class of trials called optimization trials, where really refining the intervention is the goal. And I think for oxytocin and oxytocin analogs, that's probably where we should go next to really learn how we should best use these agents. Also, if there's a role for oxytocin in combination with other agents. One thing that's really important with respect to outcomes, quality of life and social function. So we have found, and others have found, that quality of life is impaired in multiple domains in individuals with hypothalamic pituitary brain tumors. And I'm more and more interested in whether or not oxytocin may have a role here, especially given that potential signal with respect to anxiety. My colleague, Matt Hocking, has found that a substantial proportion of youth treated for a brain tumor aren't able to name a friend when asked, in contrast to other cancer survivors or brain tumor survivors, or tumor survivors rather, non-CNS tumors. So, I think this is, parents tell us this, and I'm just even more compelled by our data and those of others. Matt Hocking, my colleague, is starting a new study very shortly that when it starts recruiting, will advertise, focused primarily on social connectedness in brain tumor survivors. So what's next? I'm going to go very briefly, because people are interested in therapy for hypothalamic obesity. Back to this case, the patient that I mentioned to you right at the beginning of the talk, who had hypothalamic obesity related to pilocytic astrocytoma, we've given her a medicine from a class called GLP-1 receptor agonists. Liriglutide is the one you may have heard. So she was initially treated with insulin and metformin, and then once liraglutide was approved by her insurance, we gave that to her, led to weight loss, her ability to come off insulin, and significant improvement in fatty liver. So I'm really excited about this class of medication. An earlier generation GLP-1 agonist, Christian Roth, has presented on this at one of our family conferences. Exenatide, he has shown a benefit in individuals with hypothalamic obesity with respect to decreasing fat mass. And this was an earlier generation GLP-1 receptor agonist. So we have even better forms now. And this is, again, some data from liraglutide. So this is a patient of mine with craniopharyngioma who lost a substantial amount of weight on liraglutide. And in case any of them is in the audience and thinks they know who it is, there have been more than one who've had this benefit. I mean, it's striking. And the other hand, though, there's some folks who don't respond at all. So this is an individual with hypothalamic hamartoma whose weight continued to increase. So definitely more room for more therapies. We're trying to figure out who will respond to what treatments. So we know actually from Christian's work that folks with more hypothalamic damage actually responded better to Exenatide, to the GLP-1 agonist, than those who didn't, which is a really interesting finding that I think underscores the importance of understanding someone's hypothalamic injury when we enroll them in trials. So going back to Carbitosin, because I think, I mentioned the challenges with securing a consistent oxytocin formulation. I'm really curious about potentially this medication in hypothalamic obesity. In the Prader-Willi studies, and we were a site for these studies, they did demonstrate an effect of actually the mid-level dose of Carbitosin that they tested on hyperphagia, on excess weight. This was not enough for the FDA to approve this medicine in Carbitosin. They wanted, in Prader-Willi, they want more data. So I'm curious to see what testing will go forward there, because this agent is another really interesting option. Melanotide is being tested in hypothalamic obesity. It's a melanocortin-4 receptor agonist. Melanocortin-4 receptor is expressed in the hypothalamus and elsewhere, and folks who have genetic problems in this pathway can develop obesity. And this medication is designed to address those abnormalities and led to really substantial weight loss in folks with genetic forms of this problem. So we wonder, could extra hypothalamic, meaning outside the hypothalamus, expression of this MC4R receptor be a basis for its efficacy in hypothalamic obesity? So that trial is enrolling right now. I should mention, for folks who are not familiar, the NCT number, that's the clinicaltrials.gov number. If you've never searched clinicaltrials.gov, every United States trial is required to be registered there, and each trial has a number. So if you're looking for trial opportunities, they will be there. Triple monoamine reuptake inhibitors have been tested. Tesofensine, including in combination with metoprolol, showed promise. This was an agent Saniona had been developing. Those trials are not proceeding at the moment, but this class of medication is also an interesting one for future. And finally, just a shout out to my colleague Cassie Klein at CHOP and Fatima Mulbari, who's at Texas Children's, who are working on a clinical trial to change the way we treat craniopharyngioma from the beginning. It turns out from molecular profiling studies, there may be a role for targeted chemotherapies to help with these tumors. So for folks who present initially or who recur, to prevent the extent of damage that traditional therapies like surgery or radiation can sometimes produce. So in the interest of time, I won't summarize this again. I want to get right to your questions, but I really appreciate your kind attention and looking forward to the discussion. And thanks again to all the folks who made this study possible. All right.
Thank you so much, Dr. McCormack. That was really, really fascinating. And thank you for going to all of the, for all your hard work in trying to, in getting this pilot study done. So let's get right to the questions. Okay, first question. The MRIs that are used to diagnose a craniopharyngioma, are those the same MRIs or the same pictures that you're using in assessing the severity of HO, or do you have to do like a more specific targeted MRI to be able to use it?
What a good question. So we use the first post-treatment MRI because, as you can imagine, it's not just the tumor, it's the surgery, resection, right, that might produce the damage to do that.
Okay.
Most MRIs done at academic centers have enough detail so that even the MRI so we, for our study, used the MRIs that were done clinically at CHOP, and all of those were adequate. Francisco Perez at University of Washington, for their study, they found when they were taking MRIs from outside places that they had to repeat them for like 1 out of 5 kids to just get better resolution. But most places will get enough information out of there. And I should say, there's not a perfect one-to-one correspondence, right? There's some with more hypothalamic damage that don't seem to have a lot of problems, some that doesn't look like it should be so bad that do have a lot, but it is, I think, something that we should be looking at to help understand differences between people.
Okay, great. Okay, with the results in mind of your pilot study, would you still recommend craniopharyngioma patients try oxytocin?
That is a really great question. I know people are not going to love that. I don't think we have enough data yet, right, to routinely recommend it. I think that's part of why I wanted to highlight all the other treatment options. I'm sorry for the noise at my house, all the other treatment options that do exist. And that if folks choose to pursue oxytocin with their clinician, that they keep in mind the formulation issues, the dosing issues, the safety considerations, and the outcome. Like, what are we trying to target? And are there other ways to potentially target those things if alone or in combination to see what happens? I'm hopeful some of our optimization trials that we're thinking about will help refine the intervention so it's not so uncertain.
Okay. And in terms of the exclusion criteria, why were recent seizures included in that list?
Yeah, good question. So because of the risk that oxytocin could precipitate low sodium when given in combination with DDAVP, and everyone may know that low sodium reduces the seizure threshold, that was the main reason we excluded folks with recent seizure history. Also, oxytocin, when we give intranasally, we think it's centrally acting, right? And meaning acting on the brain. And there's a lot we still don't know, especially in folks who've had an operation perhaps, or radiation, or might have seizure disorder. And so our usual practice is to start with folks who might be safer and then expand beyond there. But the hyponatremia risk was the main reason.
Okay, that makes sense. Another question, I noticed you excluded people who had bariatric surgery. Is this just to make sure the weight loss is a result of the oxytocin being added, or is there some other reason to not take oxytocin after having a roux, and why?
No, great question. I think it was more that then we would have, like, that would be a whole nother study probably, right? Because metabolism and weight management in folks who've already had metabolic surgery is just a different entity. So that's the main reason. Really fascinating though, because weight regain after that operation is a really important area.
Okay. Is it possible to have HO without hyperphagia?
Yes, I think so. Or I think people can have what I and others have, like, when we talk, I feel like I call it like relative hyperphagia. So assessing for hyperphagia is really tricky. Like, if it's there, if the patient's reporting it or the family is reporting it, obviously they have it, right? Like if a child is, we can sometimes see in clinic, like looking around or asking for food, right? It can be very obvious. If folks say, no, my child doesn't have hyperphagia, sometimes it's because they've adjusted to a new normal, or they've had routines in place that help prevent the child from having those behaviors, or they lock fridges or other, so if someone locks a fridge at home, they will not answer yes to a bunch of the questions about stealing food. So then they will get a lower score on the questionnaire, but that's just because that questionnaire doesn't account for what adaptations people have made. So all of the assessment challenges. But then I do have patients who, for looking at how much they eat, and I really believe them, like, don't actually eat a whole lot, don't necessarily have this insatiable hunger, but have such a low metabolic rate that if they don't eat these low quantities, then they will continue to gain weight. So that's where the relative hyperphagia, right? Like relative to what their needs are, they may be eating a little bit more, but their needs are so low versus the kids who are where it's just so obvious. I hope that makes sense. Like those folks would not score high on classic hyperphagia instruments. So if we did a trial, that's what gives me pause if we do a trial that solely targets hyperphagia, then you have to have a threshold for bringing people in. So that means, if you have a medicine that you think that's how it works, then maybe that's okay. Maybe, if it only helps people who have hyperphagia, that's a possibility. But I think, you can tell I was like, we've thought about so much about this, that not everyone.
No, it's true. I've seen clients who will at first say, well, I don't think my child, or I don't think I have hyperphagia, but then in kind of doing a little bit more investigating into some of the behaviors and some of the things they're doing, it's kind of clear that they do have some.
Yeah.
Okay. So somebody's asking, does oxytocin help for weight loss not related to HO? And if so, can it be taken by somebody with DI? I think you answered that.
With HO, do you know what's interesting? Yes, well, there's that one study, right, that was done in a handful of individuals with common obesity that did show benefit for weight. Liz Lawson from Mass General is just wrapping up. They just enrolled their last person, I think, a study in otherwise healthy adults with obesity. So that questionnaires, that's a large trial. So those results, will be out soon. And for folks with DI and DDAVP, we just be very thoughtful about that risk of hyponatremia and adjusting.
Right. Yeah. Okay. I see where there are so many endocrinologists that are either unaware of oxytocin, or if marginally aware, they're unclear on dosing, et cetera. Are studies like yours getting disseminated to other doctors in order for learning to occur?
Learning to occur, yes. So we're presenting our results. You all hear more, have this ahead of the Endocrine Society meeting, which is in a month in Atlanta. So we get to share our results with colleagues there. And just by virtue of doing this study, it's generated a lot of neat conversations about not only oxytocin, truthfully, but other treatment options and what people are trying. So communication and sharing learning is always really important. But yes, we're presenting next month, and manuscript hopefully will be out soon. Okay.
Are you planning to do any future oxytocin trials in this population, maybe with a different dose, or with or without other medications added?
Yeah. So
like naltrexone.
Yeah, so I know folks are interested in naltrexone. So that's where there's a class of clinical trials called optimization trials, where it's an efficient design where the goal is not to test one particular regimen, but to quickly and efficiently test a number of different regimens when we're not sure the right way to do a certain, to give the regimen. So that's where my thinking is right now. And or if Carbitosin has some success and is approved, I'm really interested in that option too, because more has been done on dosing and we know what to do with that.
Okay, great.
And also we're thinking of other interventions besides these two. So stay tuned.
Okay. Oh, very exciting. Okay, what are the potential dangers of prolonged QT wave intervals?
Yeah, so when the prolonged QT predisposes to arrhythmias, so abnormal heart rhythms, so rapid heart rhythms that can be life-threatening. So it's a big deal.
Yeah. Okay, good to know. Okay, let's see. Somebody's asking about if their child would be a candidate for future trials, and I think they would just have to look at what the exclusion criteria would be.
Inclusion, exclusion, absolutely. For each trial, they will be different, and they're all listed on clinicaltrials.gov. It's required.
Okay. Is there a reliable way of clinically measuring oxytocin deficiency? My last understanding was that it was very controversial, even in research, saliva versus blood versus urine.
Absolutely, still controversial. The reason is in part, of course, where we care about it is in the brain. So that's the first challenge. We're not biopsying the brain to decide. And then oxytocin is 9 amino acids. That's really, really few. And so any enzyme that breaks down protein can break down really fast. So getting it stable and measuring it that way is one challenge. It also is bound to lots of different things, meaning it sticks to other things. So how do you measure the total that's bound? Do you measure that it's free? How do you make sure it doesn't come apart? So still very controversial. And I think the way we have chosen to pursue it, and I think others too, is we use all the available ways in the same study even, so that we can say, gee, if all the different techniques are pointing to the same conclusion, we probably have confidence. If they're not, then it's not. But we certainly don't have what we wish for, which would be a clinical assay, which was, the questionnaire is the way we check for thyroid hormone, right? Could we do that someday? That would be amazing. Or do we have some other test that we can perform on people, or other way of knowing whether or not oxytocin deficiency is relevant for them? I think that's a big barrier to getting to the right dosing.
Yeah. Did you find patients with hyperphagia to also have OCD?
What a good question. We did screen for anxiety, but we did not use a scale that also measured obsessive compulsive symptoms. Although that one scale in the Prader-Willi study does look at both.
Okay.
We did not use that same scale.
Okay. What was the most surprising discovery you came across in this study?
Oh, I love that question. You know what? It was the QT. I should have known that, but the literature, there's that one series, but then, I trained at Boston Children's, which is where they did that series. And I talked to the cardiologist. He said, I wish more folks knew that some people have this vulnerability, because there's medicines that cause QT prolongation, and we should be thoughtful, and it's always risk benefit, right? But monitor when we see that. So that was very important. And then I don't think it was surprising to me how much uncertainty around the dosing, but it just continues to be reinforced, like, and how different people are from each other, right? Like what really works for one person really does not. So an optimization trial or some other way of most clinical trials traditional designs don't attempt to individualize the therapy, right? It's like you all get 10 milligrams or whatever. And so we need to standardize an individualized approach to test it rigorously, which just adds challenges.
Definitely.
But it's a good opportunity.
Yes. If somebody has suffered bilateral infarcts during surgery, would that impact or their use of oxytocin?
Well, infarcts, like, so that unfortunately not uncommon for some folks. I mean, to me, that would lead to more potential damage in the area that may or may not be able to be quantified by the traditional metrics, right? So that would be the one consideration I might have, right? If you've had an injury from stroke, I don't know if it would show up the same way as an injury from tumor or surgery, but damage would seem to be damage, right? So like, I think it's plausible in the same way that would be plausible for anyone else.
Okay. I think we just answered this question. Is there a way to do OT studies with titration? So
we attempted to do that a little bit in our study. Like we had the ability to go down. We had such a short time to test folks that we didn't have a lot of time, but I think the questioner is right on that we will need to think about that.
So now that you have this sort of baseline information on safety, can you potentially do a longer study next time?
Yes, and in the meantime, since we first proposed this, there's been more studies and longer studies. So NIH supported a study in otherwise healthy adolescents with obesity. And this was as of a few years ago, we're like allowing it out to 12 weeks in that cohort. So, and then there's an autism study that folks may have seen in New England Journal. So that was longer as well. So there's more safety data now, even though this is a medically complex population. I think we have some experience that we could argue, at least we know how to monitor incredibly closely.
Okay. Is oxytocin used in Europe or other parts of the world? And do they have studies that show anything different?
It's a really good question. It is used elsewhere too. I was just talking with some European colleagues. They raised the same questions that this group has raised, in particular around dosing, and have had some experience that's similar to what our poll question said, right? Like some people seem to have some benefit and others none at all. The advantage they have is that it's FDA approved, right? So like they can just write a prescription, go to European CVS and get it. And it's, from a liability standpoint, standardization standpoint, it's off label, but it's approved. So the threshold is less, but we are working, actually, we have a working group for craniopharyngioma, and that's on the list of projects. It's like sharing our experience and learning from our European colleagues, since actually they probably are in the best position, or at least can, help us find those sources of standardized formulations.
Second to last question, how can you determine if social issues are the result of brain damage or from being cloistered to prevent overeating? It's a great question.
Well, this is not my area of expertise, but our neuropsychology colleagues would be really interested in that. If I'm hearing the questioner asks about what adverse effects from damage to the hypothalamus or other parts of the brain, and or related to the illness itself. Now the question brings up like being cloistered, but also like there's the experience of having had a brain tumor and having been in the hospital and all of those things that children with chronic illness face. So difficult to disentangle. But the paper that I showed you about naming friends, like Matt in that study compared individuals with CNS with brain tumors to other children with cancer outside the brain, right? So they share some of the same stresses. So you might compare folks, who had a brain tumor with other folks with obesity, maybe from other causes, and see, but it's tricky to disentangle those things.
Definitely. And last question, does using OT help with cognitive deficits? Memory loss, fatigue, mood?
Yeah, good question. We don't, I think that I'm aware of, I don't have data on that. The autism study that was done did not, for, you know, if I can refer folks to the New England Journal reference, did not find a benefit globally in the design they used for autism. I think autism in some ways, like hypothalamic obesity, even more, like there's so much heterogeneity there, right? So whether or not there might be subgroups or sub-strategies that might be helpful, I don't know, but I'm not aware of data that is like strongly in support of that at the moment. We had that kind of signal with respect to, anxiety and maybe impulse control that is intriguing, but I think that's what it is intriguing. It like makes us want to look further.
Okay, got it. And then one more question just came in. Are there specific studies on craniopharyngioma and social apathy?
What a good question.
Autism.
Or social apathy or autism. Well, I'm less familiar with that literature. I'm familiar with some of it. There's some literature in brain tumors broadly writ, but typically the studies are like, at least in the US, brain tumor and with craniopharyngioma as a subset, so the numbers are smaller. In Europe, our colleagues there have some craniopharyngioma long-term studies. I don't know that they parse it as finely as the questioner asked, you know, like folks use the global scale of like impaired quality of life in social areas, right? So like, but it doesn't get at why that might be, whether or not it's apathy, whether or not it's difficulty communicating, whether or not it's lacking social skills. Like there might be someone who's very interested in engaging, but they don't know how, or, you know, like there's lots of potential reasons for that. I think once we're able to advertise Matt's study for recruitment, like he is really trying to get at that more. So his study is collaborating with the autism team at CHOP. Like so I'm a co-investigator on that study. I'm really excited to be participating to look at the hormone side, but the autism group and the psychology oncology group looking together and doing some testing in survivors of brain tumors that is traditionally done in children with autism to see to what extent might they share similar kind of clinical features or presentations, if that makes sense.
Mm-hmm. Yeah. You know, I always wonder with kids that have these surgeries very, very young, you know, how much of that sort of social difficulty and anxiety around social situations maybe come from just missing this huge, important developmental chunk of their lives where they're hospitalized and seeing doctors. And if they've got hyperphagia, they can't go out and socialize very often because there's food involved. And they just don't get the practice during that time of their lives.
As well, it certainly can't help, right? Missing those developmental opportunities. But then it's like, what are the creative ways to help folks catch up in the way they can? And then if there are deficits that are related to the tumor itself, like how might those be addressed, you know, at the same way or in addition?
Definitely. Okay, well, we are just ending sort of right on time here. That was the last question that we have.
These were such great questions. Thanks so much to everyone really for them.
Yeah, thank you so much for your time, Dr. McCormack. This was really, really great. Really enjoyed it.
Well, thank you. Thank you. I think Amy may have one or other message for the group. Is that right?
No, I just thank you so much, Shana, for joining us, Marcy for moderating, and thank you to everyone that joined us this evening. This was so interesting. We've been waiting to hear about this for so long. So, and we look forward to future studies. So thank you all and have a good night.
Okay.